Good morning, all. So we've had a great session moderated by Rajarajan, and we got some wonderful insights into how the healthcare industry is beginning to get into digital transformation mode. We have exciting times ahead of us, and we, in this session, are going to give you a 360-degree view of all the trends and technologies that are going to make digital transformation possible in healthcare. So, special welcome to our extremely eminent panel. We have CXOs, technologists, clinicians, and public health experts all across India, who will give us a bird's eye view into the key elements of digital transformation from different perspectives. We are indeed lucky to have them amidst us today. To set the context, our planet is at crossroads today. We are just getting over the COVID-19 pandemic, and the entire world was caught napping with extremely poor preparedness and causing untold death and misery. We now have multiple challenges in the form of disease X, climate change, premature deaths increasingly due to NCDs, and the negative effects of artificial general intelligence, all looming ominously ahead of us. And of particular concern is non-communicable diseases. So it is the #1 killer, as we all know, and especially the cardiovascular diseases. It's a $4.58 trillion problem for India. And closer to home, Tamil Nadu has the distinction of being the diabetic capital of India. And there are over 1.5 crores uncontrolled hypertension and 73 lakh uncontrolled diabetics according to ICMR. So as you can see, we have a hugely formidable task ahead of us. And majority of these NCD sufferers are under the care of the private sector, bringing an overload on the existing system and infrastructure. So obviously there is the need to take the help of technology and bringing in an augmented connected care model, which is going to drive improved patient care delivery and safety in the most optimized and affordable manner. So digital transformation is revolutioning healthcare by fostering collaboration, as we all just saw in the previous session as well. Unless we all get together and form the right ecosystem, and there is total consistency in terms of aligning the priorities amongst ourselves, it is going to be the #1 important aspect. And then improving the efficiency, optimizing the workflows, and enhancing clinical outcomes, and ultimately elevating patient care. So according to McKinsey, this is a massive $515 billion global market by 2024. And in India, it's supposed to be a $37 billion market by 2030, according to BCG. And AI, of course, is going to play a huge role in this, a massive disruption, both good and bad. We'll be hearing from our panel experts on this. So it is going to enable this cross-platform coordination in a very big way. So across hospitals, systems, partners, and vendors, creating higher resilience, better patient placement, lowering risk, shortening recovery times, and overall improving outcomes and lowering cost, and providing the right value-based care. And this is supposed to be a huge $164 billion market by 2029. And the key components of digital transformation here is the patient-centered care, the data integration and centralization aspect, the connected care, remote patient monitoring, telehealth, the interoperability, predictive analytics, AI, ML, and the cybersecurity and ethics angles. So these are what today we'll be covering in our panel. And also a little bit about the key barriers. So today, the privacy, security, patient data confidentiality, the responsible AI and ethics part of it, and the change management, regulatory and compliance, all these are becoming, importantly critical to improve the adoption of digital transformation. So our distinguished panel today will enlighten us on all these aspects. So without further ado, let me first welcome our first speaker for the day, for session 2, Vaibhava Srinivasan. He's a chartered accountant with a master's in data science and an MBA from the esteemed Indian School of Business. He received training and design thinking from Stanford University. In his current capacity as the managing director of Availity India and vice president of Availity LLC USA, he spearheads initiatives that aim to revolutionize healthcare by leveraging technology and fostering interdisciplinary collaborations. He is driven by a deep-rooted commitment to enhancing healthcare landscape and is very active in the NASSCOM health tech community. He and his partners have brought in more than 500 people into this community. It's a thriving one, and they are working hard to go make a DTX go mainstream in the country. Over to you, Vaibhav.
Okay. Thank you. Thank you for this opportunity, Sharmila. Thank you for CII. If you find the slides very colorful, that's because I'm colorblind. If you like it, that's because I'm creative. So as you can see, I'll kind of, sorry, we'll just wait for the slides to come in. Before we get into patient centricity, you can go to the next slide. Yeah, before we get into patient centricity, let's talk about customer centricity. These are some of the top companies as far as customer centricity is concerned over the last 20 years. We probably interact with most of these organizations on a regular basis. We all know them well. If you could go to the next slide. One of the binding factors for all these companies are the deep-rooted involvement of technology that binds and captures the behavior of the customer at every touch point, right from even before they get the service, even after they receive the service, right? And any annual reports that you see, by and large, customer-centric companies are 60% more profitable than the others. A customer is 80% likely to buy from a customer-centric company. 89% of us will walk away from a company that's not really good to us, right? So there is a lot of business sense in being customer-centric. It just makes the ecosystem and the stakeholders simply much better, right? The previous panel spoke about huge, probably if you made a word cloud, data would be like the biggest word that was used. And COVID has enabled that in India significantly for obvious reasons. Everybody controls and wants to control everything in real time on the comfort of their mobile phones. And this huge surge of digital transformation that's entering healthcare has also brought in a wave of patient centricity, right? We Google, 1 out of 20 Google searches are apparently about health. I don't want to get into what results Google gives about health for a headache, but that apart, right? There's a huge urge to use, social media and other kind of platforms to get information on healthcare, right? Next slide. So with the patient centricity, and this is a quote I really love, but I'd like to pick some things which are in color. The whole objective of patient centricity is to make healthcare more accessible, and the experience is around the patient, right? It's not about what the hospitals and as caregivers can give, it's what's the kind of experience that the patient can kind of get, and use that data, everybody spoke about it, to drive into preventive care, right? Today the entire healthcare across probably the globe is driven towards solving a problem when it occurs, but not about stopping the problem from occurring. My 2 cents to this whole thing is the key for any technology, right? Patient is the center, the doctor drives the thing, but the technology is the tool. Any technology will be useful, will achieve adoption if it enhances the doctor and patient relationship. And that's going to be critical for technology adoption, just not throwing technology, but it should enhance the quality of relationship, which today is a little difficult because the amount of work and workload that the medical fraternity kind of has. Next slide, please. Okay, lot of apps, right? You have a headache, there is an app. Thank you. This is this one, right? Yeah. So there's an app for an headache, there's an app for cancer, there's an app for booking an appointment, there's an app for things. This is, all credit to my friend Ambrish for putting this together, probably a bit dated, but it's pretty crowded. It's getting even more crowded, right? There is huge amount of technology innovation in anything and everything, but they are isolated, they are not integrated as of today. But there is a huge surge among us. One of the things I forgot, and I should say, they're all people from medical community here. They're experts in technologists. I'm none of them. I get great pride in the fact that I've been a patient, full-time job as a patient for 2 years in my life, and continue to be a part-time patient, and thanks to the doctors here, I'm talking before you. But as a patient, there's a huge overcrowd of information, and they're not integrated, but I would like to have everything in the comfort of my phone, right? The traditional patient journey as we know it has changed, right? And we are driving into what is called as a digital patient journey. Let's say, some Mr. I'm trying to pick a name, Mr. Kaushik wakes up in the morning with a stomach pain in the abdomen. Today probably, we kind of find a doctor and we book an appointment, but that's going to change because Mr. Kaushik will go ahead and talk to a bot, and the bot will probably understand the symptoms. And this bot, by the way, is not Google. It's trained specifically on medical data. The bot will give you probably something and say you have to meet a physician. You'll use another, probably Ram Natation's Star Insurance will have a network where you can see what are the doctors that are empaneled, and you'll go ahead and book an appointment. Your data will be captured. You don't have to go to the hospital and fill out that forms. And then you go to the hospital, there's a first interface with the doctor knows already a little bit about this data, and then some diagnostic happens, again integrated with the lab, the results come, one for the doctor, one for a patient, which is a little bit explainable, talks a little bit more, and goes on and on and on, right? The key here is the expectation of the digital patient journey is it's going to be integrated, right? I mean, from the start to the finish, it has to be integrated, and that's how we're going to see this evolving. We talked about digital touch points. I think Mr. Anand Padmanabhan talked about IoTs. A combination of IoTs, a combination of tools will create numerous touch points. The expectation is there's going to be 20 plus touch points that will capture data through this journey. And eventually, of course, you go to a pharmacist, which is again integrated. And then, diseases such as diabetes and others don't end there. There are lifestyle monitoring, so there are wearables and other apps that will capture data, and that's going to continue, right? The journey is going to be digital, and the patients as we know it today will like to have an integral part of participating in that process, right? And that's what the digital journey is going to look like. What's different, right? Today, everything that we capture is largely clinical. The expectation in the future with the amount of information is we'll be able to capture emotional and behavioral pattern. Because what happens when we capture emotional and behavior pattern, we're able to become more personalized. How you treat me is going to be different from how you treat somebody else, because I have, besides symptoms, my circumstances are slightly different, and that's the expectation that this journey will be more personalized, right? We expect the future to be more proactive, and again, the future panel spoke about it. We spend a lot of money in only curing problems, but how do we stop the problems in the first place? It needs to be personalized. It's not a one-fit-all approach that's going to change. The patients are likely to be more empowered, part of that decision-making process. Value-based, I think Mr. Ram Natation spoke briefly about value-based. It is likely that the entire mechanism will change from a volume-based to value-based, so patient outcomes are going to be, positive outcomes are going to be incentivized significantly. I think insurance companies are doing a huge push, and that's going to be the change that we will see in the patient journey. Okay, how will all this happen, right? There's going to be large-scale adoption of AI. Today, of course, there are multiple AIs for something, for anything and everything, but hopefully there'll be an integrated solution where AI will be trusted, AI will be more trustworthy, the medical community would have been able to vet it. Everything and anything should be portable and convenient. IoT and other things will make that happen. Number of, why do you have to prick in the skin for diabetes sugar check? Maybe that'll be non-invasive. There'll be things will come to the comfort of homes. Today, the BP apparatus and others have reached. Maybe there'll be a lot more that will come in. Interoperable, I find it very difficult to pronounce that word. But anyway, I think NHA is doing a great job in kind of getting and creating the ecosystem and the platform. And I think there was a question, and I think Mr. Padmanabhan answered it very well. I think it's not far off. 5-year, 2028, the healthcare ecosystem in India will look different. A lot of amount of data collated through wearables, which will get integrated to mainstream healthcare, and personalization at nanoscale, not only the way you take the patient through the journey, but even delivery of medicines is likely to get there, right? So the way, I think a lot of these changes are already in progress. It's not that we are far. Some of the aspects are in progress. Some of them are in development and maybe in prototype stages, but that day is not really, really far. Everything has credits, but this is my personal take on this whole thing. We can do what we want, but it is essential that we build trust with the doctors, with the patients, and whatever we build. It has to be simple. I think Dr. Gautami, I think she talked about it, right? I mean, you can't overcomplicate things for the nurses, doctors, and the patient. It has to be really simple to adopt. And I'm a firm believer for technology to succeed, it has to simply enable the quality of interaction between the doctor and the patient, experience that is personalized. AI should be more explainable for the doctors to understand. It's not that the AI said it, so we have to do it, but why did the AI say it? And above most, I think the new patient-centric journey, as always, and non-negotiable is care has to be prioritized, right? So I think we're in exciting times, and I personally believe 2028 Indian healthcare will look entirely different, and all of you in this room will be integral contributors to that. So thank you for your time. Thank you.
Thank you, Vaibhav. That was some great insights into patient-centric care delivery. May I now call upon Mr. Chetan. He's the General Manager, Product Management at Siemens Healthineers, an experienced professional in the healthcare industry, focused on diagnostic imaging for the last 20 plus years. He leads product management team in diagnostic imaging's digital and automation business in India. Mr. Chetan also regularly contributes to innovation with 6 patents, 3 publications coming from 46 invention disclosures. His diverse background has led him to actively participate in a range of clinical and government engagement initiatives. We're happy to have him here today, and he'll be talking to us about bridging the gap, seamless care anywhere, augmenting healthcare through connected care and predictive analytics.
Thank you, ma'am. Being in the middle of the lineup, it's also very difficult to find novelty in what I speak, because a lot of things have already been spoken. So maybe I'll start with, before I get into the slide itself, I'll try to say the most important thing that is common with finance, aviation, and healthcare: repeatability and reproducibility of results. What I mean by this is, maybe in finance there is an opportunity to roll back a wrong transaction, but in healthcare and aviation you almost have nothing. There is no rollback once the patient's life is gone. So this becomes the founding principle as to what we do and how we do, and sometimes that is also the reason why sometimes it becomes like a catch-up game compared to any other industries. So with that note, I'll jump in. The most important thing that we need to, I think, if I try to condense all the information and the various things that we are discussing here, it really falls into this particular line where it says that where you live should not determine if you live. And this is also the theme with which we as a company work. And here I will pause for a moment and then want to really describe the challenges. So you see the map of India, but I want you to pay attention not to the map of India as the main land, but also the landmass that is there far away in the ocean, right? So we are a country, but a size of a continent, the challenges and the geography of a continent, and population definitely the size of a continent. And it also means that with that population comes the variety of languages, its own challenges and its own barriers and opportunities. But then when we look at the digital enablement that has happened, which is also breaking the geographical barriers, the language barriers, you see the kind of 5G rollout that has happened within a year. And more importantly, the UPI transactions, I don't even want to say the number. I think from the time I started speaking, probably several lakh transactions must have already got added to this number. And the most important thing is, with all of this, there are also a lot of other companies that are also acknowledging this power and the proportion of people that we have. They are enabling the language with a lot of capabilities, with the natural language capabilities, with a lot of bots and a lot of digital assistants. The whole reason I bring all of this is also to transition into the slide that as we progress further, not just as a nation, but as a world, that our population is very easily going to touch 8-10 billion. And that also means the kind of challenges that we have. Maybe in larger cities, we have all the kind of opportunities that we have for having trained staff, all kind of equipments, uninterrupted power that is all required to make this digital economy flourish. But it also means that when you want to extend the care to various other geographical locations, do we really have those kind of capabilities? And that is the challenge on one side, but while we talk about a lot of data, data is meaningless if I'm unable to mine it, I'm unable to get insights out of it. So there is an exponential amount of data. I mean, today if you see, I see my daughter every day logging into YouTube because that is also the second teacher that she has. But today the first thing that she does is she's into shorts. It is not adding any information to her, but the majority of her time she's spending on scrolling things. So we are bombarded with a lot of data, but what does it mean for us is the most important thing. So that also brings to the most important thing, that how do we navigate all of this and to find meaning out of all this information, and what kind of new innovations can we do to really enable the healthcare and to increase access to care. So some of the things that we as a company are working on, and I think many others are also working on, is the patient twinning. It's very easy to talk about patient twinning, but we are not an equipment where it is in a controlled environment and I can really look at the characteristics and then just twin it. We as humans, I mean, every time I'm in a good mood, I'll probably have some sweets. If I'm thirsty, I'll drink instead of water, I'll drink some tender coconut. All of this also means that my physiology is changing, my behaviors are changing. And to replicate that in a truly digital form, it is not an easy thing. And that is where we are also trying to shift to understand how the behaviors, the various things, not just the internal things, the environmental things also impact. And can I replicate those kind of information in a digital twin? Just for the lungs, for liver, heart, and all of that. And all of this also then leads to, why do I have to twin a patient? It also means that I need to focus on precision therapy. I mean, we have all heard about precision medicine. Precision medicine is not just giving medicine at a particular location, but it's also about giving the particular dosage for a patient. So those all things emerge from quantitative data. And again, all of this can only be achieved by the capability that we have in the abilities to mine the data and to go away from data to information to actionable insights. So this is what we are trying to do. And this is probably a bit of a crowded slide, but the most important aspect is what this slide talks about is the kind of environments in which the data is being generated. When we go to a hospital, it is a controlled environment, and we go to a hospital when things go wrong. That means it is instance-based. And when we get out of the hospital, we know that the data that is being generated is accurate, clean, and in a controlled environment. But the moment we start offering additional care of when a patient goes from hospital to home, and we want to extend it through probably population management systems and various other home health systems, the data then is probably going into different devices which is not of the medical grade. And how do I interpret the data from that? And then when I want to extend the patient and really make them functional, I'm really not talking about the generic wearables. There are a lot of medical grade wearables that you can use on a daily basis. And when the data comes from there, which is the streaming data, so that means it is in an uncontrolled environment. The devices are also uncontrolled. How do you get that information, pass it on to a hospital or backwards? And while getting bombarded with the data at the right intervals, at the right triggers, how to alarm a patient in a way that the patient can come to the hospital, or the advice from the hospital can go to a patient. So these are the important things. So that also means that, you can imagine an ocean where the bottom of the ocean is almost constant. It's not stagnant, it is constant, and it is very of high quality, but at the middle layer is a lot of current, and at the topmost thing is the place where the data is constantly changing because of wind and stuff like that. So I try to envision it like that. And with improved information, it starts coming down, and then the actionable insights actually come in. So, and this is where even as a healthcare company, we are trying to see that, okay, it's not just always the devices that we build, which are within the departments, but also how do we integrate with the Internet of Things, Internet of Medical Things, and then getting all those insights from various departments and then bringing it in a cohesive way, in a way that when doctors sit to make a decision, like for example in a tumor board meeting, can I get the information on pathology? Can I get information on the examinations? Can I get the radiology information? Can I also get information on the drug-to-drug interactions? And then, based on all of this, can I also get insights on what was the information that was available from the previous scenarios where the patient had already come? Is there a progression? Is there an arrest based on the treatments that were given? And what should be the next course of action? Today, when I try to connect with multiple systems, what happens is we are really making doctors not work like doctors, but making them as IT engineers. And when you have this context switch of mind, you really lose the focus on the patient. So as a company and even many other companies, what we are trying to do is really try to keep the patient at the center and then bring information to doctors in a way that technology is at the back end, it's not at the front end. And it's the interaction and the insights that the systems provide which help the doctors to generate timely and qualitative information and decisions that benefit the patients at that particular point in time. So this is what this slide really talks about. And it's not just limited to this, right? I mean, we have always been speaking about hospitals, but there are also companies and even within Siemens that we do where we want to extend the care beyond hospitals to place where the patients are. So that is at the societal level. We know teleradiology, we know scanners on systems and stuff like that, but there are also various wearables that the midwives, the ASHA workers, and many other semi-skilled people can go, or nurses can go, they can capture a lot of information in the field, or there are also these IoT devices at home, which are then able to aggregate the data and then beam it through specific apps, which then get monitored centrally. So there is teleradiology is for sure, all of you know, but then there is also tele-ICU concepts that are coming in. Then there are I'm forgetting the name, but tele-ICU is for one. And then the most important other aspect is that there are many people from the hospitals here who are trying to expand your services to various other locations. But are you also able to get skilled workers in all of those places? Probably the answer is no. And you might want to also do the scannings remotely, an MRI scan, a CT scan, the advanced scans. Even those kind of offerings are also being done in a mixed mode with people, as well as some things offered by the AI systems. So that is the kind of thing that is being done to increase access to care. And with this, I'll probably pause here. And the most important thing I also want to tell is, as I showed in the first image of India, our challenges are slightly different because of the scale. And I think we have no problem with the quality of care that we get. The only thing is, as we embark on getting into the digital revolution and add on a lot of systems, we should also be sure that we don't overwhelm our healthcare systems in a way that they are swamped by data and not being able to focus and provide the same care to the patients. So with that, I'll pause and thank you all again for this opportunity.
Thank you, Chetan. So your thoughts on repeatability, reproducibility, precision therapy, and overall, the virtual scans, that's very interesting. So thanks for the inputs. Now, may I call upon Mr. Sanju Sudhakar. He's a national lead and key accounts business and market access from Roche Diabetes Care India. He'll be talking to us on the global health challenges from challenge to change, harnessing digital transformation for a healthier world. Yeah. He's a business leader with over 18 years of diversified experience in medical devices, pharma, and hospital industry, and has held senior positions in corporate and commercial strategy, business development, and commercial operations. He's working currently with Roche as a national business, national lead, key account business and market access, where he manages hospitals, government relations, retail chains, and pharma corporates. Over to you, Sanju.
Shamla, thank you so much for the introduction, and good afternoon, one and all. And I just want to thank CII for this opportunity. So briefly, I'll be talking about current challenges in terms of our healthcare systems. Let me just go to the next slide. Yeah. So please pardon me for this crowded slide, but then, sorry. So what I want to highlight at this point of time is, currently we have a lot of challenges, right, in healthcare. The increase in disease burden, 60% of the deaths happens because of NCDs. But then it's important that we look at challenges where technology has a larger role to play. Hence, I thought of putting up these slides. And the most important, or one of the most important barrier, I would say, or red flag at this point of time is the lack of quality of data. I heard clinicians speaking, like they don't have data coming back to them to make decisions. Similarly, not only for clinicians, even for management, right, to take a decision, they need data. That's not coming in. It's important that we create an ecosystem or an environment where we integrate the data. And also there is insufficient use of data. So whether we talk about insurance, whether we talk about medical device, whether we talk about hospitals, we don't use our data neither discreetly or appropriately. And the other challenge I want to highlight is basically the insufficient skilled and qualified health workers. We want our health force to be trained more on IT, more on machine learning, so that they can come up and use this technology in our hand. And also, compromised quality is also one of the concerns. More because we have protocols, but there hardly any adherence to protocols and guidelines, even at some time at a clinical level also. Now, in terms of cost and efficiency also, is one of the biggest problem, and where technology can come a big hand. And it's also because of the burden of manual processes. We all know that healthcare, is expensive at this point of time, and technology can come there and play a larger role. So once we understood the challenges, it's also important to look at what are the current digital tools that can make a difference. The most important thing I want to talk about is about telemedicine. I think Dr. Schoff is one of the pioneers in this area, and he also happened to be my mentor. And post-COVID, see, we have seen 500% increase in teleconsultations, and so far we have done 1 billion consultations. So this is here to stay. I know this is going to be hybrid. This is not going to be purely teleconsult, but then this is something that we as a community should nurture. Electronic health records. Many of the organized hospitals have EHRs, but then these EHRs cannot talk to each other, neither to the system at a government level. So I appreciate the noble initiative of Ayushman Bharat Mission, where they're bringing an interface where they can integrate all the HMIs together. So this is something we all should look forward. This is also an era of robotic and assisted surgery, where precision medicine will improve the precision of surgeries, quality of outcomes, and down the line, next 4 years, 40% of surgeries will be robotic. And at this point of time, robotic surgeries are expensive, but then I'm sure with advent of new technologies, the cost is going to come down. The role of connected ambulance will continue to grow, because this also gives real-time data back to the hospital. For example, there are a lot of trauma cases that happen, a lot of patients we can save in the golden hours. Next is all about the self-monitored devices. Now, most of the self-monitored devices like blood glucometers and say blood pressure monitors have digital capabilities and connectivities. But then the usage should increase at some point of time, because neither there is an adherence from the patients, and there is also lack of willingness from HCPs at this point of time to improve the adoptions. We already heard about IoT and virtual reality, importance of that. The mHealth and patient portals, somebody spoke about individual data, when is going to come. So this will become reality in next 2-3 years. We have also Ayushman Bharat, coming up with a unique ID. And at the same time, there are also a lot of patient portals where individual data can be saved, stored, retrieved, and at the same time, managing the confidentiality. And I also want to talk about the organs on chips. So I come from a pharma industry, and we spend huge amount of money and time on drug trials. Time has come, scientists have invented organs on chips. For example, they have invented liver chips, where drug trials can be done. So this can save huge amount of money, time. and also about 3D printing. So we all talk about predictive analysis. If 3D printing can go next level, the predictive analysis can be much, much better, and saving lives, saving outcomes. Moving to the next slides. So I'm very proud in the fact that India is spearheading the affordable digital solutions across the globe. And why affordable digital solutions is important? See, 70% of healthcare spend is still out of pocket. And ironically, 70% of these expenses is spent on drugs. And as per the latest data, 60% of the people move to poverty because of their spending on healthcare. Hence, it's very important that not only we talk about digital solutions, but we also talk about affordable digital solutions. I want to share some of the examples. See, our hospital industry, they have moved ahead in terms of this. For example, a cardiac surgery has been done in $1,000, while in US it has been done between $20,000 to $60,000. And even company like GE, they have come out with portable ECG machines and scanners, which are much more cheaper. Talking about company like, sorry, I'm taking name of companies, but then they have done tremendous work, in the healthcare. Companies like Biocons, they have come with oral insulin, cheaper. So this will make insulin consumption much more cheaper going forward. Companies like Roche, where I work with, they have come out with cheaper biosimilars for oncology care. Hence, it's very important that we as a forum, we as a community talk about affordable digital solutions. And a couple of elements is basically, it's important that we also talk about delivering value-based health services. I heard one of the leaders from the insurance company talking about paying less premium if you do 10,000 steps. Similarly, healthcare systems also. For example, a surgical ward or a surgical wing can follow the protocols and improve the outcomes. So this should be incentivized. And our government is also doing a lot of work in terms of digitizing the entire ecosystems. They're going to come up with HPR, the Healthcare Professional Registry, where they're going to integrate all the healthcare professional data. Similarly, they're going to come up with a unified health interface, where all the EHRs or HMIs can be integrated and data can flow seamlessly. And finally, the time is not very far when we all will have a unique ABA number ID like your UHID. So what we want to propose as a team is basically, we should work towards a solution that is integrated, where there will be elements of patient centricity, quality healthcare delivery with continuum of care at all levels. It should be AI-driven, device agnostics, and the platform to collect and integrate robust data. And we are also able to integrate healthcare delivery, whether it is payer, provider, all the players in the ecosystem should be integrated. Finally, I want to share a small example. So Roche does a lot of work with governments. So of late, we've been part of a pet project of Chief Minister of Tamil Nadu, which is called MTM projects. It's called Makkal Thedi Maruthum, where they have done door-to-door screening for blood pressure, monitoring of blood pressure and blood glucose. So they were doing plain screening before. So we had an opportunity to collaborate with one of the companies, that's Vincennes, where we have digitized this entire program, and the results were mind-boggling results. The government could really understand number of diabetes patients who need chronic care, who needs optimum care. So those kind of data have been mind-boggling, and we've been asked to now expand this program across all other states. So digital solutions has a big role to play. And my final slides talk about the healthcare opportunities. We know how big data is important. Integrate all the data at all levels. Right from your lab, right from your tissues, to your providers, insurance, we need this data. And I'm sure at some point of time this become reality. And genomics, The genome patri should play a very important role in terms of predictive analysis. The NCD burden is huge in our country, and I'm sure in next 3-4 years, we all will have this genome patri, and we all can take preventive measures. Connectivity continue to spearhead, and artificial intelligence is going to play a major role in all these things. While going through all the presentations, now I feel that at some point of time we'll be replaced by humans. Sorry, but we humans will be replaced by technology, and I also feel threatened. But I'm sure technology will play a bigger part. We will find more better jobs. So at some point of time, we know that we might lose jobs, but then we all should encourage digital solutions and support each other, share business models. That's all. Thank you so much.
Thank you. Thanks, Sanju. The point you made about having affordable digital solutions is very important. That's when I think the adoption will definitely take off in a big way. Next, we have Mr. Kaushik Rajendran from Amazon Web Services. He's a highly experienced healthcare IT leader who's currently a principal solutions architect at AWS India. He has a deep expertise in healthcare and life sciences, which he leverages to help AWS customers improve patient and business outcomes through data, AI, and ML. He worked with Healthify Me to build ML models for detecting Indian foods and creating a virtual continuous glucose monitoring solution. He's a strong proponent of India's Ayushman Bharat digital mission and has pioneered efforts to promote interoperability and adoption of ABDM across the country. So who better to address us on the key aspects of cybersecurity and interoperability, building trust in bits and bytes, interoperability and security as the cornerstones of digital health. Over to you, Kaushik.
Thank you, Sharmila. Good morning to all of you. I think I'm going to talk about some of the key trends we see as AWS. So we work with a number of customers across the globe, and recently we have started working very closely with a number of healthcare organizations within India and also across Asia Pacific and Japan. And I think this theme of interoperability is very important. I'll tell you why. So before moving that, why interoperability, why we are talking about bringing all the data together, standardizing the data, and how it's going to help you, right? So the first is, what we are looking for is a healthcare system to become more faster, reliable, and cost effective and accurate from technology perspective. And at the same time, we also want to improve quality of care, improve clinical outcomes, and also business outcomes and administrative outcomes, while keeping the cost and security at check. Now, we at AWS, we have a mission of helping our customers deliver highly personalized healthcare by leveraging technology and making customers make use of their data and kind of standardize it and whatnot. Now, if you look at interoperability, again, in the interest of the group, I would like to kind of step back and try to explain you what interoperability means and why it is important today. Now, there are as per HL7 and HIMSS, which is a very prominent bodies within healthcare ecosystem. They are defining interoperability in 4 stages. The first stage simply being ability for two clinical systems to be able to talk to each other. Now, the second being, okay, I know 2 systems can talk to each other, but how, right? What if we define schema or data structure of how data can be talked to each other? Like, for example, let's say 2 hospitals sharing data. Let's say if patient schema is fixed. Now, when you exchange data, both systems will exactly know where to find the relevant information. Now, the third stage is basically semantic interoperability, wherein it's not only about the syntax or the structure, but also what if the language is making sense, vocabulary is making sense. Because we as a country, even within one hospital, we'll find every doctor writing in their own way. There's nothing wrong about it. It's just the way they've learned. It's just the way they've evolved into the system. Now, what if you bring in certain mechanism to standardize those data into vocabularies like ICD, SNOMED, LOINC, RxNum, or whatever? and then you exchange the data. Now, two systems will be able to exchange and understand the data even more. Now, the fourth level is more of an organizational or a very high level interoperability, which is fairly advanced, where this is where Ayushman Bharat health mission and everything comes into picture, where it allows multiple organizations to come together, exchange data, bring down cost, meet equitable care and whatnot. So, if you look at this, Ayushman Bharat is at the fourth stage, like where it envisions to allow all the healthcare ecosystem to talk to each other, and I think really welcome the move of bringing in National Health Claims Exchange or HCX protocol as part of the ABDM ecosystem, which I clearly see from our side that it is accelerating the adoption of interoperability itself. Now, I can tell, like, recently I've been working with one such customer called Ika Care, who is known for a patient health repository app. Have been able to totally build using some of our technologies in building Ayushman Bharat integrations, and that is being used by a number of patients from their side. And there are hospitals who are already actively building Ayushman Bharat related integration with us. Now, what it is facilitating them is to now bring all the data from all the disparate clinical system into one common data lake or perhaps data warehouse, whatever you want to call it. Now, again, let me go back to the question of why we need to do it, right? From a hospital, what is the ROI? Why should I do it? Because just by building ABDM, is my organization going to meet my objectives, not only from clinical side, but also from my business side? The answer may be ambiguous at this point of time. But if you look at this process of standardizing the data, once you standardize the data, your ability to build predictive models and decision support system and everything will be much better and easier. Now, for example, if you go and talk to a doctor in a hospital, they may not immediately be receptive of talking the idea of building ABDM based system. However, if you go and talk to the medical officers of the hospitals, they'll all agree that they have a lot of research programs and clinical research and the need for building predictions, not only from the operational side and administrative side, even from clinical side. Like, for example, it could be about predicting the length of stay. It could be about predicting the risk of readmissions for diabetic patients on certain procedures. Now, there could be a number of use cases. Now, these are prevalent use cases that every hospital is trying to solve. Now, to solve this problem, your systems must be interoperable, your systems data should be integrated and standardized so that you can take advantage of some of the open source algorithms and models which are available out for you. You don't have to start from scratch. There are a number of models, number of clinical systems available for you. So you can take advantage of it, jumpstart your innovation from there and quickly build your intelligent system. Now, this is where we are working with customers on variety of such use cases. I think from previous panel also, Ananda Batnaban and Ram also talked about the importance, how the clinical systems and the providers and payers can all come together to take advantage of what government is building. And now if you look at it, when you do all of this now, you can also analyze, like you have interoperability system, now you have models, data standardized. With all of this, you can actually also build something called population health analytics, or in terms even at a hospital level, you can analyze patients at various disease conditions. You can build like a disease specific risk strata dashboards or care gap analysis or whatever to understand your patients better, or learn from your patient cohort and improve your clinical protocol and which eventually is going to improve patient outcomes. Now, at the same time, Sharmila also talked about another important aspect, security. Now, security is job zero, as we AWS call it all the times, because it precedes every other priority in your organization. Now, security, compliance and privacy can be broadly looked at, because sometimes it could be ambiguous, sometimes it could be tedious. In fact, sometimes it could also be a blocker in adopting certain technology. But I think we should understand the local regional requirements of the law, and at the same time, let's say when you're working with various enterprises, there could be a new set of regulations that they may be wanting. So you should always look at technologies and tools that enable you to do that. Now, for example, now I think everybody is very gung-ho and excited about all these possibilities with foundation models, large language models, chat-based large language models and everything. Now, how many of you would have tried to take a very sensitive classified information into it, like it could be patient data, it could be just your own data, for example, and put into those systems without thinking about where this data goes, how this data is going to be utilized, and simply just like, for a sake of extracting some simple information. very commonly we see this mistake happening all over. So there has to be a sense of responsibility across the table. So we call something called shared responsibility model. Security, compliance, even ethics, and everything should be a shared responsibility. Now, depending on the vendors, could be cloud, could be any other digital systems, or even like clinical systems. Whenever you are partnering with them, should critically evaluate what are your shared responsibilities. Now, when it comes to data security, who is going to be the custodian of the data, who is going to securely store the data, whose job is to encrypt the data, what happens if some kind of a security incident happens, right? Are you going to, what is your protocol to work on fixing that problem, whether your data is reliable, all of that comes into picture. Now, most importantly, recently you would have started hearing a term called responsible AI. I'm going AI direction because a lot of topics are around that. If you look at responsible AI, there are few significant things that you need to keep in mind. Number one is obviously the explainability. Now, explainability, what is explainability is your model, the AI system that you are using should be able to help you understand or explain why it is inferring the outcome that it is giving you. So there should be clear evidence in like where or what statement made the model to think about that particular inference and giving it to you. For example, let's say we have a solution that basically transcribes the whole audio between doctor and the patient and converts that into standards, and in fact converts that into CCD notes or SOAP note kind of a standard template, push it into EMR system. Now, when a customer is building that, now let's say if the data is going like with certain symptom, now we need to understand why that symptom is predicted that way. Now you should be able to go back to the inference, from there to the audio to connect the dots, and so that your system is explainable. Now the next is basically, sorry about that. Yeah, the next is about fairness. Again, some of the models could be trained in a different backgrounds. For example, let's say if you have highly metro specific population in your database, and let's say if you have trained your model based on that, what if you take the same model and apply it to a rural setup? Now the inferencing values could be totally different. Now, some of the models we may be using could be totally trained from North American or perhaps from European data sets, and that could not be relevant for India also altogether. And finally, transparency, because like I mentioned, end of the day, the model should be able to totally help you understand from what data set it has been trained and why it is making the inference the way it is and everything. So in fact, all of this should be put in factor. So when you are actually being the force multiplier in helping your organization build all these advanced tools and technologies, keep in mind about security and be responsible, and always build this protocol from ground up. So with that, I'd like to hand it over to Sharmila.
Thank you, Kaushik. That was some really great insights into the all-important security and responsible AI angles. And you're right about the ABDM. It was going to be a game changer, and hopefully it will make equitable and accessible care for all in the years to come. Our final speech is going to be by Dr. Ganesh Kumar Parasuraman. He's a medical scientist at Indian Council for Medical Research. He's one of the rare combinations of tech savviness and clinical excellence. So I've learned a lot from him personally. We've had multiple brainstorming sessions on how to make the digital transformation happen across the country. And he's a field epidemiologist and implementation science expert with over 14 years of extensive experience in public health research, training and implementation. He holds a prolific publication record with over 60 research articles featured in peer-reviewed journals. He has successfully led and contributed to more than 20 funded projects spanning non-communicable disease surveillance, and digital health domains. And today he'll be addressing us on India's journey, basically in public health digitization, navigating the digital frontier. Over to you.
Thank you, Sharmila and CII, for inviting this event. So I believe that along with my colleague, Dr. Joshua, we are both who are from the public health sector of the India, especially working on this area in this particular group. I've been listening right from the morning about the conversations happening around the digitalization on the clinical domain, especially in the private sector largely. And and I believe that like it is all associated with in terms of the claims, in terms of like improve the quality of the delivery, improve the patient safety on that. But somehow this never happened so easily in public health. Of course, there are multiple reasons which I assume I may be wrong, and of course, it's all driven by market forces in private sector. A lot of digitalization, automation on the managerial aspect of an hospital domain, or in terms of improving the claims or identifying it, or improving the diagnostics. It's all driven by market forces. I'm just putting it across, but that market force never exists in public health. But fundamentally, in my experience, when I started my public health journey from University of Delhi, we explored the public health, digital health space. At the time, the digital health terminology was not there. WHO preferred to use a terminology called e-health. Okay, so all are all synonymous, but fundamentally it is using computers in the healthcare delivery. Okay. But the problem here is that in digitalization, especially in India's journey, I will love to share my experience, what has happened in this space, and also try to collate that experience from the various programs, how far actually we've been doing. Of course, I believe that in private sector, in hospital domain, in clinical sector, and as well as related to diagnostics, there is a huge amount of noise around artificial intelligence and every other thing. But practically, if health is concerned, the majority healthcare provider is government. Okay. When it covers, compared with that, it is very difficult to even the government to provide healthcare for the citizens of the India, fundamentally to upkeep and improve their health status of the population. Definitely we need a private and as well as a non-governmental sector to support it. So over a period of time, if you see that the role of digital health in public health has gone into multiple directions, but I am trying to concise it on very few important things which is really required. I hope clinicians in this room will be agreeing part of that, because they also need such information which I have been listening from the morning. One is for public health, for any healthcare provider, be it is a clinician or it is an hospital or it is a government, who is investing their resources to improve the care of their citizens, fundamentally they need to identify what is the pattern of the disease in that particular population, be it is infectious disease or it is non-communicable disease. I will share two experiences on that. One is the disease surveillance to detect the disease outbreaks. We've been more educated because of COVID-19 on this particular aspect, but fundamentally we've been running an integrated disease surveillance program for very long years, trying to detect outbreaks. I prefer to say trying to detect. We really haven't achieved well because the data didn't exist in the form it is to be analyzed to detect the outbreaks, but we have improved a lot on that particular part. Second, in non-communicable disease, I will share some of my experience. I closely work with government and the private healthcare providers. I work with 25,000 primary health centers through our project, India Hypertension Control Initiative, to improve the hypertension care. Fundamentally, the most preferred way of maintaining the data is only paper-based form. Let us be very practical. Okay. Second experience I will tell about COVID-19. COVID-19, when I closely worked with the three governments, including Tamil Nadu, Puducherry and Goa. I've been supporting technical support during COVID-19 for providing technical decisions related to response to COVID-19 since 2021. But what has happened there is entirely a different thing. Usage of digital tools was very fantastic, but I will tell you what digital tools was actually used in the ground. Second, the most important use of digital health in public health is public health program monitoring. You never know how much amount of crores being invested for public health programs, be it is immunization program, maternal child health, non-communicable disease including cancer and cardiovascular diseases, then in terms of like infectious diseases, which is burdening the health system throughout the period. Okay, in calamities it increases. When we are implementing a program through the resources, we need to have some indicators where to monitor where we really need to invest, where we no need to invest more. For that, the digital health part, which we tried, I'll share that. Third is community-based healthcare delivery by non-physician staff. We all agree, we no need to repeatedly say that. It's not about the doctor population ratio, it is the doctor density in which particular population. Of course, doctor density in the sector where it is. Some of the states which I closely work in the central India and the North India, population less than, say, like there are some community health centers and there are primary health centers, there are health sub-centers in the public sector. We don't find doctors below community health centers, which is the majority healthcare provider. 80% of the care is majority healthcare provider. This is still there. Despite operationally, functionally, whether a doctor is there or not, no, it is not there. Fundamentally, the healthcare provider is a non-physician who is a nurse or a healthcare provider who is popularly called as a community health officer or mid-level health provider or a healthcare worker. But when we try to empower it in our experience on hypertension management through that particular healthcare provider, phenomenally we have found the results. The control rate compared to district hospitals, it has improved among the enrolled hypertension patients. This is a reality based on what I am talking. 40 lakh patient records we have been monitored in the past 5 years through this India Hypertension Control Initiative. We implemented that in 140 districts, 26 states, and based on 40 lakh patient data, we found that the health and wellness center, which is at the grassroots level, the healthcare provider is a community health officer and MLHP. When they provide a care at that level, it is accessible, affordable, patient gets continuous monitoring, control rate increased phenomenally. Fourth one is that we need to provide continuous capacity building and support to the healthcare providers who are at the grassroots level, where we need clear and knowledge management. Definitely, you all know that YouTube is the best learning management system which is currently being available, where people are accessing that information on any skills, how to find a formula or how to use formula for an Excel or how to make a better presentations or even how to cook a best khichdi. Whatever it is, that YouTube is one-stop solution. We never know that has been disrupted. Of course, it is unregulated. It has a lot of noise also in that. Then I want to share that the largest digital public health interventions which has happened in India, these are all the digital public health interventions. When I say these, then these have either had a potentiality or will have a potentiality in order to do consistent public health, digital health interventions. There are multiple ad hoc digital health interventions happened in this public health space. 3 years, an application will be there, a portal will be there, then it will be rolled out. Then after that, it will not exist. Either it doesn't exist or it is not used. If you see this list, that integrated disease surveillance program, which is the national health program in order to detect the pattern of the diseases and the disease outbreaks across the India through their reporting units, is through the IHIP portal. This is one recent innovation which has happened in the past 4-5 years. We have a very good data which is coming up. Again, second problem, data use, it is not that much. Data generation, it is there, but data use, no. You have data, but you have food, but you don't want to eat. Simple. Because I don't like that food, or it is not in a likable form. We don't know that. This is one thing for many clinicians where we need an answer. We want to know the pattern. Second, cancer registries. I didn't mention here, but I want to say cancer registries. We have a cancer registry, quietly a representative, both population-based cancer registry and hospital-based cancer registry. Please believe me, all the public health decisions or the data related to the cancer is generated only through those cancer registries. Fundamentally, if you ask me whether private sector is providing what is the proportion in terms of infectious disease in IHIP or in cancer registries, I would say negligible. They are not participating in it. Of course, we could blame government is not coming and talking to us, but it doesn't work like that. You all know it. It's something like we have to take extra efforts, consistent efforts in order to bring this data to there. Definitely, it may be a very representative, a huge amount of a population is being taken care of in the private sector for infectious diseases and as well as for certain non-communicable diseases. The biggest another data which we have currently is on after the IHIP, the second is that Pradhan Mantri Jan Arogya Yojana, which is a health insurance scheme by the Prime Minister. Huge amount of data is been there by National Health Authority of India. Again, huge amount of data, whether it is converted as an meaningful information, there is a lot of work to be done. It is happening, but a lot of work to be done. But I find when I reviewed the literature and I also explored it, the health insurance sector, despite it is government or private, it is not generating a clinical information out of it. Managerial information you can say. You can say about claims this much, this state has more claims. It's all driven by market forces, I do understand that. But does it provide from the clinician's point of view, if you ask like when clinician, okay right, of the entire number of CABGs, bypass surgeries done or the heart attack stunts whichever has placed, how many of them have been survived, what is the age distribution, whether the private insurance sector is publishing it? No. Government publishing it, it has to be done. So this is one thing which you need to know. Third, COVID-19 vaccination, COVID, which is one of the largest database. Again I am telling, database means data is there. We have considerably analyzed this data, COVID data. It has produced a huge amount of implications in taking decisions. Definitely, when we collaborated with the states, this particular data used them to take decisions where we need to identify the at-risk population and strengthen their vaccination. They are now going to include the child immunization module also into COVID. Ayushman Bharat Digital Health Mission is going to be the future, it's a simple UPI of health. It's a universal payment gateway interface of health. It's Ayushman Bharat Digital Health Mission. I have huge hopes on that. Lot of work to be done. Definitely, if you think government is the only only sector is going to do this space, no, it has to be combined and lot of private forces has to pull in and actively participate and advocate for certain things. E-Sanjeevani, many of you are aware about it. Of all these things, like now the current comprehensive primary health care for NCDs is getting built, which have been closely working there. And we have seen that like from our experience of India Hypertension Control Initiative, we have transformed that particular digital health tool there to CPHC also. So what actually I am trying to say when I mentioned in my previous slide, what is the commonest digital health tools which is used in the public health at the ground by the healthcare workers, district health team, by the medical officers, by the nurses during COVID and also now currently these are the tools. Please believe me. When I closely work in the ground, these are the tools which is being used. Many of you have been talking about data security and all those things. Fine, fantastic. We don't have the luxury to think about it actually. We need actually job to be done at the ground. When I went along with this ground and I've been supporting this huge amount of patient data is being maintained by Google Sheet. Why? We can collaborate. When the patient is coming from one center to another center, testing to another testing, when I enter it, another person can log in, share that particular sheet, they can enter the further details. Simple. Then they finalize, put a master data in Excel and store it in their hard disk. Then they want to take decisions. We have been thinking about dashboards and all those things. Fundamentally, large amount of decisions are taken by PowerPoint. Okay, and of course, it is not so user. I mean, what is called? It is not design based. We don't have that capacity in the public sector to do that. Never happened. Digital health literacy is not that much. So visualizing data mostly by tables were taken decisions. This is what has happened. During COVID, what I have closely seen is that WhatsApp is the one fantastic digital health tool which is used widely across India. Okay, right. And this is a common communication platform even now. Okay, right. When I interact with a bureaucrat and say that, so this is what we have to do in terms of it, can I share it in email? No, please WhatsApp me. Simple. And I've been there for nearly some 25 WhatsApp groups related to the COVID at the time, and we've been sharing all these communications during WhatsApp only. And WhatsApp is the most important tool which is used. Why WhatsApp? Why Google Sheet? We need to think before user-centric designs where Mr. Vaibhav has talked about it. Because it's user-centric, it's simple, it's free. Okay. Then Google Meet and Zoom is used. Mostly Google Meet, which I have seen in the field because that's free. And it is fine. I can use it with the mobile phone. I can use it. Definitely not MS Teams. Sorry if any Microsoft partners are there. But this is what the reality which has happened in the ground. I wanted to share that to you. So determinants of a successful public health digitalization are, this is based on my field experience and observation. These are the things. One, User-centered design and user research is very critical, which decides the longevity and consistent usage of it. Second, cost is a major factor in digital public health, which decides. Offline first, does not depend always on internet. Offline first. It should work on offline, it should work on, then synchronize the data, then it should be inbuilt within the device. Operates in low bandwidth, and it should be very fast. Do not hang. If it hangs a couple of times, they don't use it. Then why they are using WhatsApp and why they are using Google Sheet, then we need to think about it. It do not hang, okay? It does not. And it is very fast and mobile friendly. So these are the determinants of successful public health digitalization. And finally, I just close my discussion with all of you is to how to better digitalize the public health is ABDM ecosystem, which is mandatory. There is no other go. Second, portable patient-centric IoT devices, which will empower the healthcare workers at the grassroots to take decisions. User-centered, co-created apps. We did in our India Hypertension Control Initiative. We developed an app called Simple. The name of the app is called Simple. That only recorded 40 lakh hypertension patients and diabetes patients. Using Simple, we created along with the nurses and doctors on the ground, and it should be cost affordable apps and digital products. And public health, the data lakes is one major thing which is going to rock. Huge amount of data being generated, but what actually are we doing with that is the biggest question on that. Thank you for this wonderful opportunity. Thank you very much.
Thank you, Dr. Ganesh. That was amazing insights into our public health systems. And obviously, digital transformation is the only way to go if you want to strengthen public health systems. And along with that, only if private and public work together, things can happen for the good of the population. So now I would like to get some remarks from our co-chair for the session, Dr. Deepak Srinivasan. He's a senior consultant at MGM, a highly accomplished and proficient surgeon, and an impressive career spanning over 16 years, specializing in laparoscopic, general GI, and bariatric surgery. And he has expertise lies in a diverse range of areas, including hernia repairs, abdominal wall reconstruction, weight loss, metabolic procedures, malignant and benign gastrointestinal surgeries and proctology. His contributions to the field have been recognized with the prestigious Best Laparoscopic and Bariatric Surgeon Award at the Global Healthcare Excellence Award in 2018, attesting to their exceptional skills, dedication, and significant impact on surgical innovation and patient care. Over to you.
Thank you to CII, and it's been a wonderful opportunity. Usually I'm in a gathering of surgeons where there is one healthcare IT professional coming and talking. This feels different completely, where I'm probably one of the 4 or 5 doctors here who are probably sitting here. But it was a great session. I think all the kudos to all the speakers. I got a different perspective about the whole aspect of digitizing healthcare. A few points, I think most of it has already been mentioned by many of the speakers here is, I think one thing which, Dr. Ganesh in the end mentioned was, even though he mentioned that it is well taken up by the grassroots level nurses and the other things, I think it's the simplest thing is having something like a Google Sheet or an Excel. And most of the times, how much ever we try to have a video consult software across for your hospital, etc., many times our patients, my own patients, they just make a WhatsApp call or a video call, they send the reports to us over WhatsApp. So it's sometimes very difficult to say no to that. We have to accept that, but at the same time, we want to make it into a very, get it into a system, and so that it's acceptable and the data can be captured, but many times it does not happen. So I think it is very important to have the system very, very simple. And reproducibility, as quite a few people said. And yes, one thing which is very, very need for the hour is the integration between the public and the private healthcare systems as a common level. Because I think if that does not happen, the whole idea of a unique healthcare ID or a unique healthcare system to have gather your data and use it for whatever purposes in the future is never going to happen. And yes, of course, security, as mentioned, it's very, very important. I think patient confidentiality and many other aspects come into picture. So I just want to say, take one aspect from each one of the speakers and just say, A good, probably, what is required is probably a simple, reproducible, affordable, interoperable, standardized, and a responsible, a digital healthcare system, which is probably universally and integrated with both the public and the private. Thank you.
Thank you so much. That was well put in a nutshell. Now we'd like to throw open the questions to the audience. We can take a maximum of 2 questions. Yes. Please introduce yourself and please keep the question short as we're running out of time.
Thank you very much. It was a very enlightening session. My name is John, and I'm on the other side of the table. I prepare the future medical leaders. My question is directed to Dr. Ganesh. Dr. Ganesh, you provided an overarching system of how public system uses digital data, and the digital health infrastructure is a work in progress. What intrigued me is that the public health system is sitting on large amount of digital data, both structured and unstructured. Would you be open to provide that data to academic institutions to analyze it and use the evidence-based health policy formulation? Thank you very much.
Thank you, Mr. John. I represent Indian Council of Medical Research, National Institute of Epidemiology. By any academia, I also face the same kind of difficulty when we try to access the data from a public health or a larger data which is sitting in the government, try to analyze it. The question is not the attitude not to share. The problem here is that it may not be available in a shareable form. We have to build a huge amount of capacity from not structured or unstructured, even in a shareable form of a data. I don't want to mention an organization, which is a government organization, but I wanted to say that they have been providing an organized healthcare delivery for, I would say, like nearly 2 crore beneficiaries within their ambit. I have a recent interaction with them at the top leadership and also try to deal with the digital health lead or the health informatics lead. What I found is that that particular system was built 10 years before and still it is running. The government has been mandating that every healthcare worker has to enter the data into that when they are providing the care. But despite all those things, whatever is happening, they cannot able to even take out a data in a simple table out of it. This major problem here is that it is not an attitude of not sharing. Definitely restrictions will be there. Over conversations and advocacy, it can be one. But the most important thing is that is not in a shareable form. That is where we need to work a lot, how to make the existing database into a shareable form. Thank you.
Thank you, Dr. Ganesh. Yeah, please go ahead.
I'm Paul Dayanidhi. I'm a professor in college. My question to the forum as such is, AI has been made as a core subject in all fields of engineering. I think Dr. Ganesh Balasubramanian is aware of it. He's working with Tamil Nadu government. And Anna University College of Engineering, India has set up an AI lab, which is common to all. For now, Tamil Nadu government chief minister has made a very articulate statement that AI lab will be there in 730 engineering college. Why don't your health center, for example, in Tiruchendur, can get connected with the Adityanar College of Engineering and analyze with that AI lab so that the students of the engineering colleges will have a more innovative and cost-effective solution. That is my honest request. Because the Tamil Nadu government chief minister has told that 730 engineering colleges coming under Anna University will have an AI core lab like what is set up in College of Engineering in India. So suppose, for example, I am from Tiruchendur, native of Tiruchendur, Tirunelveli. So Adityanar College of Engineering will also have an AI lab. So why don't your primary health center in Tiruchendur can get connected with the Adityanar College of Engineering AI lab so that a cost-effective tool can be made to innovate rather than depending on Google and Excel sheet. That is my honest opinion.
Thanks, Professor, but it is other way around. So you never know that how a primary health center actually is more chaotic in terms of an operations. Day-to-day needs varies. Every day, nearly 150 to 200 patients role into that. The primary duty of a medical officer is to treat the OPD patients and as well as take care of their healthcare workers. It is the other way around. Academia need to reach out to the, not the health centers, but at least talk to the leadership, Directorate of Public Health or something. There is one better way to do that, I would suggest openly. ICMR and other funding organizations keep on publishing call for proposals on digital health and public health. Academia need to actively participate. Even recently, we are reviewing some of the call for proposal for the digital health, which is published by ICMR. We have received not great proposals. We have received some proposals. Some have been represented by top academia only, like IITs and other things. But academia has to actively see that what are the different calls, and they need to develop models working along with the government to demonstrate the model. This is what it could be working. So that's the way that we can proceed. That's the best way, and that's the scientific way of doing. Definitely in public health, no one is not going to believe you. I will tell you honestly that I hope Sharmila may not disagree that during COVID-19, I would say nearly more than 50 different digital health providers have reached out to the government. Not everything were adopted. There were different dynamics plays a role in terms of adopting the digital health. Despite whether it is working or not working, it is not the most important thing which is deciding it. There are other dynamics which is deciding part of it. But academia should participate in this call for proposals, develop some models based on the funding from these funding organizations, and then we have to reach out to these governments and say that why don't we adopt it in the health centers. And one simple note I wanted to mention related to AI in health. Of course, many have been very excited about it. There is a recent publication from New England Journal of Medicine Digital Age in November 2023, this last month. They analyzed nearly some 10 billion claim records from 2018 till 2022. On analyzing that, what are all the different AI products? This is usage of medical AI devices and products in healthcare. What it is found in US healthcare, 10 billion claims, when analyzed it is very minimal, negligible. Most of them were used only in academic settings and universities and very highly competitive hospitals. A majority are related to some of the few rarest diseases or few diseases which is of importance. The true usage of AI at the ground level, I know there is a lot of noise, I am very cautious about it, I am equally excited like any other, but it is not there. We are not there. The availability of indexed data, like what ChatGPT had of 175 trillion data, we don't have that in healthcare and medical. We have a long way to go. We need to work on the data first rather than the outputs. Thank you very much.
I just want to add a couple of pointers to what everyone said. In fact, both the questions are in same direction. I just want to call out a couple of trends that we are seeing, right? One is like a couple of days back, UK Biobank launched 500,000 whole genome sequencing data for public use, meaning like anyone who is a researcher or could be an academia or anybody can actually take advantage of the data and train it. And from AWS, we have set aside two projects. One is called the Registry of Open Data, called RODA, which has number of public data sets that one can take and use to train or improve their models. Now, second is very recently, I think a couple of days back in the RSNA event in Chicago, our customer or a partner, I would say, has announced a model specifically built for medical imaging. Now, what will help is to basically, the model is trained to understand the medical imaging, converts image to image or like text to image. And in fact, let's say if you're taking an imaging for a particular patient, whether that imaging is enough or should they take like additional image from a different dimension or modality. Now, all of this can be inferred by AI and everything. So, in a way, we are heading there, but obviously it has to be a collaborative effort from all parties. Like for example, we from AWS, we also collaborate with various government initiatives, including CoWIN and a few others. And at the same time, we also have to nurture the ecosystem, right from the startup to the academics and also to the government. And I really look forward to that particular time.
I also want to make a small point here. While we talk from industry, academia, healthcare perspective, as a patient, what I've experienced in the West, I was admitted to a hospital, again from one of the leading hospitals where I'd gone to offer some healthcare as a provider. For whatever reason I was admitted, the chief radiologist took me to the emergency room. He told that this guy has come from India and throughout the day he's been suffering, please take care of that. 3 hours later, the nurse first appears and then they have a battery of questions that they need to fill. The whole point that we are talking about, to get the data in a structured form, the patient suffers. And what Dr. Ganesh is trying to tell is that we cannot put this ahead of the patient. And past all of that, then the doctor actually appeared. I mean, I really felt that it was God appearing in front of me at 12 in the night, and then he again went through the list of questionnaires that he was supposed to ask, because it's not that he is wanting to ask that, it is the regulation, it is the checklist, everything that mandates, which prevents healthcare being offered. All of that passed. Next day I went with this whole big prescription to CVS or Walgreens, whatever it is. There was 2 patients in front of me, 1 behind me. When my turn came, I handed over this prescription. I asked, okay, the first thing that the lady said is, there is a lot of crowd. Can you come in the evening to collect medicines? I was slightly perplexed. I said, I'm really sorry. This is the first time I'm getting admitted as a patient. I want to understand, but where is the patient? She really went ballistic. She took it personal. She said, don't you see the number of people? I said, I'm sorry, but I'll step aside. I can wait for 40 minutes. You know what? It was not the inefficiency of the person, but the amount of paperwork that person has to do to get the data in structured form. So I think none of us here, when we become patients, we want anybody from pharmacy or doctors to tell, wait a minute, I need to fill in the data in a structured form. So unless and until technology becomes non-obtrusive, I think AI will always take the back seat.
Just one comment, and I'll quickly finish this. And see, I think many of the times it's always said that, the change that is that the healthcare, the digitization brings in is not accepted by doctors enough. And it's always a long drawn battle between the person who's giving us the system and the doctors. I think the change has to come from a grassroots level, and I think it is very important that part and parcel of your basic medical graduation, I think digitization should be part of it, EMR should be part of it, and that's when, when I'm already used to writing a prescription by hand, which takes me 30 seconds to do, if I'm asked to do it initially, it might take me about 6 to 7 minutes. I'll want to always go back to the 30-second pathway. But if I've started to train from my MBBS times when I'm doing my internship, and that becomes a system, it's easier to adapt. And I think that is why the system should be universal. Whereas if I go to X hospital, Y hospital, Z hospital, it should be a similar system, whereas each one should not be different. And that's my one last take on it. Thank you.
Thank you so much.
Sorry,
we have gone over time, so we really have to have a hard stop here. So I thank all the panelists for their wonderful insights, and I think we all agree that digital transformation is very much on the way as far as the healthcare industry is concerned, and the most important aspect being the collaborative ecosystem, and particularly between the public and private sector. Thank you so much.
I have a question.
I have a comment. I am the oldest man in the crowd.
Of course, we are honored to have Dr. K.G. Bhaktavatsalam.
I've been sitting here for the past 3-4 hours. It's a great organization. You and your brother have done it. I have lived in America for 2 years. I returned to India in 1974. I've been running this hospital called KG Hospital for the past 50 years. And I entirely agree with you. You must be an American in the brain and an Indian in the heart.
Thank you so much for your kind words. And now over to the next session.
Sorry, ma'am, may I ask? Excuse me. Yeah, I have a question to ask. Sorry. Sorry for extending the Q&A.
We can take it offline, no problem.
Fine.
Yeah?
Thank you.
Thank you.